Good morning, everyone. Welcome to the TPA meeting here on March 22nd. We will give everyone a moment or two to get settled in. While we do that, we will cover a couple of things coming up on the TPA's schedule. We'll remind everyone that we are recording today's meeting. Following the meeting, we will distribute a copy of the presentation slides, recording of the meeting, any handouts that we use today. So thank you for joining us. We'll advise everybody if you have a question for any of our panelists today, to please use the Q&A. You're welcome to use the chat as well for any comments to the group or our panelists. We'll be monitoring more closely the Q&A for any questions that you would like to be asked publicly. So we will go ahead and get started. Again, welcome to our membership meeting here today. I'm very pleased we have some great guests to join us. A few changes in the lineup. We'll get the revised agenda posted here shortly. Craig will be joining us in a few moments, and we have a few handouts that we'll post for all of you today. We will be being joined by Jeff Musty, Drew Simonik from Station MD, by Constance Harrington from Shift. We're very eager and anxious to get into a lot of that information with you here today. And also, we've also added to our list of panelists today, Nancy Murray. So Nancy, I want to welcome you in right away. I know you have some limited time. And as we kind of get to our first few housekeeping and agenda items, one of the things that we want to make sure that we highlight are the upcoming meetings and events. Coming up very quickly, I just want to begin with the Dan Miller Disability and Mental Health Summit. So Nancy, are you on with us?
Yes.
Okay, well, thanks. Welcome. Thanks for being here today. Yeah, I see we will get the agenda posted here momentarily. We had to make a few last minute edits. I want to make sure we get the right version. So I'm going to wait on Craig to post that. We do have the agenda items kind of listed out on screen as we go through the presentation. So welcome, Nancy. I thought it'd be good to bring you in and also kind of help out with looking at the upcoming schedule. So I want to mention a couple of things briefly. We do have a performance-based contracting workshop. We talked about this last month at our meeting. Given what we've learned about performance-based contracting in terms of the forthcoming waivers, the publication of rates that'll be happening very soon, we're probably going to push that back. We're looking tentatively as early as April 26th. We may go into the following week. We would like to see the published information come out before we host the session. We'd like to be in the best position possible to really talk about exactly what's in the waivers. You know, what do the tiers look like? What does pay for performance look like? We expect simultaneously the proposed fee schedule rates to be effective July 1st, to also be published at or about the same time. So there'll be a lot of new information that we'd like to have at our disposal before we actually have that session. So our next virtual membership meeting, because we're going to be at the Regional Learning Alliance live next month. We will simulcast that for those of you who aren't attending in person, but we also want to list out our May 31st virtual membership meeting. We'll also do our annual meeting virtually on June 28th. So as we jump in here, Nancy, I'll let you kind of comment. I know you attended the meeting with Representative Miller and his team yesterday. We've been talking about this session. We've been promoting it a lot. So we want to advise everybody that it is April 18th and 19th, a two-day session. This will be held at 1900 Cochrane Road, Pittsburgh. What we've shown the zip on screen. And recent announcement is that we have Governor Shapiro will be a guest at the Thursday session. And so Nancy, that's a big development. I know we've put that out to TPA members. I'll remind folks that if you haven't registered yet, that session will close. Rep Miller made that pretty clear yesterday. Due to security reasons, they're only going to have so many people in the room. The names of registrants will have to be shared with the administration and such. But nice development that Governor Shapiro will be attending in person at the Rep Miller upcoming Disability and Mental Health Summit. So Nancy, let me bring you in and have you comment on a few things that you've heard and some of our upcoming plans.
Yeah, a couple extra things. Actually, the Lieutenant Governor, Austin Davis, will also be with Governor Shapiro on April 18th. If you have not registered, please register because there is going to be a maximum number of people allowed in the room. And there are going to be extra security precautions. As soon as we get them from Representative Miller in the governor's office, we'll be making sure that all TPA members have those extra security issues that we need to follow also. But it's going to be a great day. We're also asking you as TPA members to reach out to your House and Senate members and invite them. Patrick and I are going to be sending out and Craig are going to be sending out an invite to all legislators, if not today, Monday, but a follow-up email from you inviting your rep, your senator would also be wonderful. Thanks.
Yeah, so we're really looking forward to this. So I want to talk a little bit about the couple of days and how it relates to TPA events as well. And then we'll kind of get into some of the budget update information. So we're going to go to that next, since we have Nancy for a limited amount of time, and she's really involved in that as the chair of our Government and Advocacy Committee at TPA. But, talking a little bit about, going out about a month from now. So the Disability Summit is Thursday and Friday. The keynote on Thursday will be Governor Shapiro. That is an 11 to 12 session. Again, you can go to disabilitysummit.com, register for everything. There's also a pre-conference session, but I think we're showing it on the agenda. Again, we'll get that agenda posted shortly. April the 4th, this is kind of geared toward families, but it's a virtual kickoff. It'll actually be about the PA budget from the advocate's perspective. I'll be participating in that along with Richard Edley from RCPA and some professionals that Richard works with on the budget with our CPA. So we'll be doing a 1-hour session at 2 p.m. on April the 4th. So the event itself will be the 18th and 19th. Again, 1900 Cochran Road. That is Bethel Congregation. As of yesterday, though, for security reasons, we are not promoting the Bethel Congregation name. That's a request of Bethel. So we will be putting the address out. We'll be changing all of our materials that are posted and everything going out so far. Or going into the future now until the event to just identify the address per their request. So the zip code, this is the Green Tree, Scott Township section. I think it's pretty much right on the border. So as you're heading out, basically 279 to the west. So I think many of you have been there before. It's a great venue, 2-day event, a lot of breakout sessions, really bringing it back to what it was several years ago. So Governor Shapiro will be the keynote on Thursday. We know that will be a very well-attended event. There are going to be legislative panel discussions each day. So there will be one from 2 to 4 p.m. on the April 18th session, the Thursday. April 19th is really sort of TPA day. We are going to have our April meeting live in person from 11 to 12 at 1900 Cochran Road at the site. We will be one of the various listed breakout sessions. So if you haven't registered already for the summit, you can simply select the TPA membership meeting as the 11 o'clock breakout that you would like to attend. This will be open to the public, so we'll have an opportunity to meet with various other people who will be attending the summit. We expect many parents may choose to attend and learn from us. So we will do a regular meeting. We will definitely simulcast, broadcast that through either Zoom or another platform, so members from all over the state can join us if you can't come in person. And then from noon to 1, as we did last year, we will be hosting our legislators. So we've invited all 251 members of the Pennsylvania General Assembly. The keynote on that day will be County Executive Sarah Innamorato. So we will be inviting Sarah to join us at our legislative appreciation IDA awareness luncheon. Of course, Sarah recently was a member of the House. So we're very grateful for the opportunity to work with Representative Miller and for the generosity of the folks at Bethel to give us the space, work with us. One of the things I want to point out is that the luncheon, we will provide lunches for the legislators. If you would like a luncheon, we are asking registrants to pay for the lunch if you're going to attend and actually have lunch with us. There's no requirement to do that. You can still attend the forum and you don't have to eat if you want to eat lunch on your own, which is basically how the summit is set up. But we did want to make sure we had lunches available for the reps and senators who are going to attend. As Rep. Miller reported to us yesterday at his update meeting, he's had several people RSVP. They are also inviting people that they invite to our luncheon. So we do hope to have an opportunity there. These topics won't come up in the legislative panel discussion, which essentially functions as a House and Senate joint hearing on the IDA issues and matters affecting the budget in the IDA community. But we will have that dedicated 1 hour hosting the legislators for lunch to be able to talk about all these issues. We certainly want to introduce them to family members, DSPs, talk about the provider story, obviously workforce waiting list being very predominant in our messaging. So With that, I'll just do a quick reminder. Shortly thereafter, coming up live, we will again be at the Regional Learning Alliance in Cranberry. This will be July 26th. We will have an all-day session at the Regional Learning Alliance. Kristen Ahrens has already devoted her time, the time of her leadership team. If you recall, last year, Kristen and the leadership team from ODP, as well as some other great guests, attended and stayed with us all day. We did panel discussions into the afternoon. We're planning for a similar format this year, so we'll give everybody a heads up on that. Look forward to seeing you there. So without any further delay, let me kind of get into agenda item. Really when you see the agenda posted, and is how the agenda was actually prepared. Pennsylvania budget update, item number 4. So we're going to go to that next. So Nancy, these are the things we'll circle back to. We have the advocacy toolkit. We have the campaign to support the proposed budget out there live in terms of what we can give you as members as an easy way to do outreach to your legislators and still to Governor Shapiro to thank him for making this historic investment into our service system. We want to talk a little bit about grassroots outreach to our legislators, obviously involving all of you folks as members and the people that you work with. And we'll talk a little bit for just a couple of moments about our the next steps in our unified advocacy. So quickly, Nancy, I know you're a little bit limited on time. Anything you want to jump in with? I just wanted to remind everyone that we've heard from the governor, we've heard from the Secretary Valar Kush. They've really sort of put their Bridges to Success theme into this budget, and the foundations of health. What has been communicated for the IDA community is really pretty much on this particular slide. This is the investment in rates, the investment to open up new waivers for individuals from the waiting list. The plan is really to eliminate the emergency waiting list over this multi-year plan. And you can see some of the details that we can talk a little bit more about. But I don't want to delay things any further, Nancy, give you a chance to speak. This is actually the line items. Again, just with your limited time, Nancy, I'll quickly get to the most recent meeting we had. We did a session on March the 4th after our last TPA meeting. We opened up the GNA committee meeting for anybody who wanted to learn more about advocacy, how to do outreach. And again, many of you are already doing this, and we thank you for that. I just wanted to show the advocacy toolkit. This is up and live, and all these resources are available to you, including the ability to download our talking points that we've done jointly with the other associations, a draft letter you can share with your legislator, and a lot of really good collateral information is contained here. Simple, straightforward. But Nancy, let me bring you in. So I thought it was a really great session that you had a couple of weeks ago. I know you continue to meet weekly. So how do you feel about where things are at right now?
Well, a lot of work went into getting to the point that we are right now. As you all know, as we've reported in the past, we met with Kristen, Secretary Arkush, Secretary Munson, the budget secretary, multiple meetings with Akbar and Meghna Patel in the governor's office, with Lindsay, all the way up to and including the governor himself. The governor, as you all know, has proposed $217 million of state funds, which will draw down about $266 million in federal funds to increase wages for direct support professionals through increased rates. In addition to that, there is a proposal of $34.2 million to bring another 1,250 people off the emergency waiting list. Right now, we have an historically large emergency waiting list. It is now, I think, a little bit over 6,000 people just on the emergency waiting list. Our job now is not over. Very, very simply, we need to buckle down and make sure that we are reaching all members of the House and the Senate with particular emphasis, particular time spent visiting all Republican senators. There is a lot in the governor's proposed budget that will never get funded. It just will not get funded. We know that. And after all the work that's gotten into getting us to this point, all of the 6,000 people on the emergency waiting list, all the providers across the state who find it almost impossible on a day-to-day basis to cover shifts, to hire and retain good staff, providers who want to do more, to bring people off the waiting list, to start new programs. Everybody's just stuck where we are right now. The governor's proposed budget will give us, as Patrick said, this is an historic commitment to the IDA community. So our job is to continue to push forward, to meet, as I said, with every House and Senate member, especially the Senate Republicans. This week, we had quite a few TPA members in Harrisburg, meeting with, as I look at my list, probably about 12 of those Senate Republicans. But that does not mean all of those Senate Republicans are going to vote for our funding. So what we are asking each and every TPA member to do is to schedule a meeting with your House and Senate members, keeping in mind, again, Senate Republicans. Meet with them, take DSPs with you, take individuals with intellectual disabilities with you, families with you. We know that the family that Governor Shapiro met with back, I think it was last June, I was in the meeting. I will never forget that meeting, the way that he truly, truly listened to my friend Cindy Jennings. You could just see it happening in the room. As the bridge on I-95 was collapsing, we're in this room with the governor, and he is listening to one Pennsylvania family talk about the struggles of continuing to care for an adult child at home who requires 24/7 care. So we have the attention of the Shapiro administration. We know there's a lot of support from House and Senate members, but we have to get to the point where the people who are going to be sitting in the room at the last moment, those are the people that we need, especially the Senate Republicans, to make sure that the funding that has been proposed, every last dollar, stays in the budget. So I'm going to be reaching out to many of you individually. Those of you who I know who are in a district where there's some people that we absolutely need on our side. And in the meantime, schedule those meetings. If you have any questions about, how to schedule a meeting, what actually to do in a meeting, don't hesitate to reach out to Patrick or me. We'll walk you through some, answers to your questions. And in advance, I thank you, because it's now up to us to make sure each of those dollars stays in the budget. Thank you.
Nancy, thanks for joining us today. Appreciate your time. Appreciate all your efforts and the efforts of everybody on your committee, and all TPA members. So, we'll just, to wrap up on this segment, I just want to emphasize that, you see the numbers on screen that Nancy was talking about. So this is money that the governor has put into the budget. Nancy just mentioned, her friend Cindy Jennings, Matt Jennings, Matt's grandmother, Cindy's mom, Judy. They were at the budget presentation by the governor on February the 6th. Governor Shapiro, if you go back to last fall, announced the review of rates for the IDA community at the National Alliance of Direct Support Professionals National Conference in Pittsburgh. So he has shown a lot of personal commitment making these connections. But if I harken back to what Secretary Harkush said at her briefing following that February 6th announcement, budgets don't pass themselves. So that's why we're really urging everybody, unlike previous years where we were asking the legislature to put money into the budget that the executive budget did not include from the governor, we have a big head start this year. So we recognize also that you don't control who your legislators are. So we want a grassroots effort where everybody hears from us. And really, it's as simple as tell your story. We have some pieces of information that kind of condense what's in the budget. But basically the budget is what it is. It's what the governor has said he is investing. He has made reference to this can increase rates by 12%. We know that the total investment into rates is estimated to be $483 million. So this should be significant for the system. The 34.2 million that Nancy referenced, really, again, these are state dollars only, so they will be matched further by the federal matching dollars. So this is to address waiting list, more people coming off the waiting list, most importantly, workforce to increase capacity. So anything you can do, any questions you have, anything we can learn from you as you sort of encounter obstacles along the way. But one of the things we're trying to combat is really the fact that we want to make sure everybody understands as much momentum as there is. And as much as you're going to hear even about some of the tangibles, even in this meeting today, this budget is not real until it's passed by the legislature. So those are the folks that are in your control to do outreach to. The campaign we have set up is actually set up that you can ask for a meeting just by sort of clicking. You don't have to ask for a meeting. You can tell your story. You can alter the text in there. But if you look at what's on screen now, urge the PA legislator later to support investment in IDA services. That goes directly to a voter voice campaign. There's a description of what that is, and you can send a message directly to your senator and to your House member using that link. So thank you all. Thank you again, Nancy, for covering this for us. Plenty more information. You're always welcome to attend the Monday 9:30 meetings if you have questions, information. Extend a note to me, Craig, Nancy. You would be welcome to come in, learn more, or talk about what you would like to do to help support the effort. So with that, Craig, I think you're available to join us. I do want to talk about, and I thank you, Craig. I think the agenda is posted. So for those of you that haven't had a chance to follow along so far, I know it's been there for a few minutes. We do have this new membership portal for TPA members. Craig, I'll welcome you in and just let you talk a little bit about what you want to say about that briefly. And then I want to kind of have a conversation with you about maybe some of the implications.
Yeah, so hi, everybody. We have continued to move forward with our new platform. We are working through the design features that is the member-only portal, which will allow you to access member-only benefits. But in order for us to begin to build some of that out, and when we talk about member-only benefits, what we're looking at are things like a place where your organization can post jobs and share them among membership. We're going to be developing some forums where what you might be used to seeing as committees, like our compliance committee, for example, where you can post questions and work back and forth on issues kind of real time instead of waiting for meetings. And a place for us to post anything that we can around some of the other benefits with group purchasing and some consulting relationships and things that Patrick and I often get questions about through the information at Provider Alliance email. So as we develop that, one of the first steps to move that forward is that we need to be able to set up member-only logins. So all of your organizations who are members of TPA are already set up on our new platform. And we're going to be putting out a survey to collect some information about who should have access to this site. From your organization. So you look for that link. Once you get that link, you'll be able to put in the name and the email address of the individual in your organization that needs a login to our site. We'll set those up and our system will email those users automatically that their accounts have been established. And once that's in place, then we will begin the next steps of sort of rolling out some of these other products that are available to us to hopefully, in the long run, increase the value of the Provider Alliance membership to all of you in your organizations. So Patrick, I think that's sort of a high level questions.
Yeah, thanks, Craig. And just to emphasize, we know we've been getting some questions. We thank some of you that are trying to get in, and you're bumping into some of the login things. As you probably already know, we've converted to a member elite platform. So I think that gives us a world of new capabilities. I'm going to roll those out as we sort of feel ready to do that. The login is really the key to all of that. So why we want to emphasize this is if you don't have a login, it's going to kind of roadblock you from forum, job postings, and even the free attendance of meetings. As a TPA member, you get to attend everything for free, and that extends really to everybody associated with your organization. So we're open to certainly your DSPs, your family members. So we want to make sure everybody has access. So we will gladly set that up. But I know right now we don't have all the users in that we want in and that we think you would want in. So what that means is, the next time Kristen Ahrens or ODP or any of our special guests are here, anybody can come and join if they're a part of your organization. You just have to let us know that they need login credentials, because as you're starting to see, as you log in and register, and then there's going to be members only parts of the platform that only members can access. So that login will be extremely important going forward. So that's why I want to emphasize that. So thanks very much, Craig. And anything more you want to say just as we wrap that topic up?
No, if anybody has any questions about the site or you have any issues navigating it or you see a little, snafu or something doesn't perform the way you think it should, just shoot us an email at information@provideralliance.org and we can troubleshoot and get those things resolved.
Thanks, Craig. So I want to go here just before we get into our featured guests today. A few other things that we want to cover on the ODP front, and then a few other just basic IDD and ODP updates as well. So performance-based contracting, as I mentioned earlier, we want to do a session that will kind of be themed around what you need to know, and what you need to know in terms of policy, what you need to know in terms of how to succeed in the world of performance-based contracting. So, we have kind of a lineup established. We've reached out to Kristen to participate in that. We really, as I said earlier, want to make sure that we have as much published information in front of us as we talk through that we can share and exchange with members, get your feedback. Again, we expect rates as well as the waiver language. So as you know, up until now, we have a lot of discussion about tiers, about pay for performance, but we really don't know the details around that. Once we see rates, we'll have more insight on rates overall and also rates within performance-based contracting. So reminder that for residential habilitation services, January 1, 2025, the upcoming January 1 is when this will be effective. 1 year later for supports coordination services. So we think it's very important to get the information, assemble membership, and also try to deliver some of the important information that we feel that we want to discuss and have in terms of everybody's ability to succeed in this new environment. So the publication, we do expect that to occur hopefully no later than the 26th online publication date, 27th of April. That's why we feel like a session on the 26th might be the earliest possible time. If it does come out a week earlier, which is a possibility, it'll give us another week for us and you to kind of digest that information, formulate some questions, and then walk through that at our session. So these are the things that are really very, very predominant right now. We want to continue to keep this in front of membership, keep tabs on the implications of it, and we will announce that session as soon as we can nail down exactly when we can have it. And we have certain people we want to participate in it as well. So we look forward to announcing that very soon. The other items that we want to talk about, we put out an announcement yesterday, a couple of nights ago. The U.S. Senate passed a bill that relates to the establishment of SOC code, a standard occupation classification code under the federal government. This is part of the Recognizing the Role of Direct Support Professionals Act. So we've talked for several years, working with our colleagues, working with NADSP. A lot of folks have been promoting this, the importance of having an actual code identifying a direct support professional, which does not exist currently, which makes rate setting kind of murky because there's no federal data on DSP. So this will take a while to get in place. If it's finally enacted, it needs to go through the House. And it will take some time really to build up good data around DSP wages and compensation as well. But it's a very important first step toward making sure that direct support professionals, as the bill states, are actually recognized. As large as they are in the workforce, as important as their work is to what all of us do. So we're very excited to announce that. We also know that about a week ago, maybe a little bit longer, the CIS-A discrepancy form was released under ODP announcement 24028. We have that posted. We'll keep tabs on that. That's also an issue where we feel that our advocacy is really around making sure that there is a good exception process for those situations where an updated CIS score is just really a tremendous reduction to the needs and what you're investing in terms of supports for folks at the current time without a gap. So we will continue that discussion. I also want to mention last month when Rick Smith was here, the one-time supplemental payments that came out of basically repurposing money in the budget. A new waiver amendment was written that was put out for public comment. Those comments were due on March the 4th. When Rick Smith was here last month on the 22nd of February, he noted that the NEA, the needs exception allowance rates, would be excluded from these one-time supplemental payments, 6% of 6 months of claims in the period January or July 1, 2023 through the end of the year, December 31, 2023. So we spread the word on that. Thanks to all of you that reached out to us to highlight this issue. Rick did state it. We took a dive into it. Our understanding is that this will be changed. It will not go to a full 6%, unfortunately, but our understanding is it will move to 3%. There will be a few other tweaks and changes made. We're not exactly certain of of the other changes, Craig, if you're able to post our comment letter, we asked for basically three things. To eliminate the need for providers to need to request the funds through an application and approval process, the flexibility that if there was more money available in the line item that supports IDA services, community services, that the flexibility would be allowed, that they could push that money out to the provider world and not necessarily have it possibly be reappropriated as occurred last year. And then we called out in a pretty big way the NEA, being that the NEA rates are really supporting the most needy people in our system, and to carve them out of that. We also didn't see that the language allowed that carve out. So you can take a read of the comments. We know that other associations, other provider members, other people with an interest in these issues also commented. I have not seen a summary of the public comments yet, but we think that that's all very important. We're glad for some of the movement and progress. We will continue that discussion so that we can have more progress, hopefully, before that's enacted. So with that, Craig, if there's any questions on anything, I do want to sort of move into the rest of our agenda because we have some very special guests with us today. So I want to
Patrick, we do have a question. Are providers still required to apply for these funds?
As far as I know, yes. I tried to reach out to Rick Smith this morning to get clarification in terms of our request on that. I haven't heard that they've really budged on that. If you listened to Rick last month, he was pretty firm that they felt that that was something that was important. We're not really sure why. Of course, they end up having a lot of money left on the table because certain organizations don't apply. They have to figure out, they have done the calculation anyway. They should know what the claims are because they're in promise. So we're going to continue to lean in on that. My conversation with Kristen was very brief. We only had a chance to talk about it for a few moments at the end of the meeting I had with her. So I do understand she's announced it publicly. I wanted to get a few more details from Rick, but we will continue to ask that question. We will continue to really advocate that the money should just go out without the delay or administrative complications or delays related to an application process, but we don't have an answer for you on that yet.
Okay,
and I want to move on.
We had one other comment
Okay.
about the difference between the 3% and the 6%. So maybe you can talk a little bit about the difference between the two of those.
Yeah, I can just comment my own opinion, which is, we didn't know anything that we didn't know there was a carve out for NEA until Rick said it. If you read the announcement and you read the waiver itself, again, there was nothing in there that would indicate to me that there was a carve out. They talked about fee schedule revenue. Now, NEA rates are not on the published fee schedule, but they are fee for service revenue. Nevertheless, that's approved. They are billed as a code. So it was a surprise to us to learn that that was the intent. So I think what we further understood, and I think Rick said this last month, they didn't really say 6% based upon an inflation factor or some arbitrary or independent metric. They just looked at what they felt they had available and did the math and said it's 6% for 6 months. So once they did that, that probably inhibited them to add more money to it. So maybe they felt they had room to do 3%. Their argument is that many of those rates get appealed. They're intended to be paying providers up to cost. As you'll read in our letter, we acknowledge that it's an intent to pay more and understand and appreciate that, but nevertheless, it's a fee. And we also know that they're not fully approved, which is oftentimes why they are appealed. So we just felt that it was fair, particularly this group of individuals, that they should certainly qualify for the 6% that everybody else in the system is getting. Again, just a straight percentage calculation of that period of claims times a 6% factor. But that's really all we know at this point. I think it is good to know that there was some movement based on our comments, your comments, raising awareness of this issue. I think it will boil down to, does the state have additional funds? And I think we will learn more when the spring update conducted basically in April of this year, the same process that really enabled and facilitated the clawback of money last year. We've called that out. We've called it out in advance in our comment letter. And if there is more money available, we will certainly press to know that amount and to make sure that that is pushed out into the community IDA system and not lost for some other purposes. So I do want to move on and bring in Jeff Musty, Drew Simonik. Craig's going to be a big part of this because Craig has worked with you guys and has, I know, some great data from his perspective. So Jeff and Drew, welcome. Thank you for joining us today. We really appreciate you being here. I know we had a chance to visit a little bit earlier this week. So as per our agenda, these are the things that we talked about. I think we all agreed these are good topics for you guys to talk about, but this is really your show. So I want to welcome you in, give you guys a chance to introduce yourselves, and then we can have a little conversation about what direction you would want to go. And Jeff and Drew, I know you have some presentation slides you want to walk through, so feel free to put those up and share those anytime.
Great. Thanks, Patrick. And yeah, thanks, Patrick and Craig, for having us on here and everyone on the call. We're excited, obviously, to be here. This is a recent update for Station MD in Pennsylvania. But yeah, my name is Jeff Musty. I'm Director of Strategic Accounts here at Station MD. Although I cover a good portion of the country, I happen to be from Pennsylvania. So this is close to home for me, obviously. So we will share a little slide deck here, keep it brief, obviously, walk through Station MD, our services, and how we recently became an approved provider of the STAT service. But before I do that, Drew, do you mind introducing yourself?
Yeah, thanks everyone for having us on the call today. My name is Drew Simonik, and like Jeff said, I'm the Member Relations Specialist of Pennsylvania. Jeff will share our information once the slides are done with our contact info, but myself and Jeff are the go-to people for Station MD here in Pennsylvania. But thanks for the time today.
All right, thanks, Drew. Yeah, and again, we'll keep this brief, but just to run through a little bit about Station MD. So Station MD is a specialized telehealth for individuals with IDD. That's all we serve. So we're really here to help people with IDD thrive in the community. Although we're called telehealth, I think we're much more than that. We're here to answer any medical question that comes up, medical advice. We have physicians available around the clock to answer those questions, all specialized physicians I'll highlight in our presentation here. So just quickly, where did Station MD come from? We were founded by emergency room doctors. There were 4 of them that founded us originally back in 2016. They were all treating in the ER and saw that gap in care. They were treating these individuals and said to themselves, we didn't learn this in medical school. Now I know that's expanding, thankfully, as we're moving forward, but they didn't have that knowledge. And they saw, residents coming out didn't have that knowledge. So they really want to fill this gap and have the ability to treat a broader population of individuals with IDD and hopefully prevent some of those unnecessary visits to the ER, urgent care, and potentially preventing even unnecessary admissions to the hospital. Again, as I mentioned, our docs are all specially trained and focused for the IDD population. So when they come in to Station MD, we have a curriculum developed. They have to go through many hours of learning and tests to take before they could start treating. But on top of that, they also have treated over 44,000 visits last year, well over 100,000 since we started. So they have a lot of real cases that they've went through to utilize that knowledge to treat others along the way. We have obviously highlighted here, we won some awards along the way. Really just kind of highlighting that we have been recognized by this population, this whole niche section of healthcare, and we're continuing to develop that and obviously treat more individuals across the country. So just before I get started, a little the specifics of Station MD and the STAT service. We are an approved provider, again, of the STAT service as of March 1st this year. So just looking at it, what is a STAT service exactly? It is 24/7 access to physicians every day of the year, including holidays. As I mentioned, these docs are specialized and have extensive experience with this population. One part of our workflow, we do treat, obviously, an assessment just like any physician. If they decide during the treatment they should go to the ER, that's probably a necessary course of treatment for them. Our docs actually call the ER ahead of time to give that kind of warm handoff, care coordination, give that ease of transition to the hospital, and have that peer-to-peer conversation. Our visits are not static. So if we visit with someone here, our physicians, and they feel they'd like to follow up, maybe there's some questions still to see how that person's doing. We do have an aftercare type program that nurses may call and check on that individual. The doc may even call as well within a couple hours, maybe the next day, just depends on the case. Also, we have the technical ability to interface with your EMRs. So sometimes we get logins to address kind of uploading our notes to your systems. Sometimes we even fax notes, email notes, but just knowing that once we have our documentation with our EMR, we do share that with you all after that visit. And we have plenty of staff here, technical assistants and receptionists that will help throughout the call, and I'll run through that process in a little bit. So you all know this very well, but where we kind of came from is because many people with IDD have no choice but to go to the ER in many cases. So obviously high risk, multiple comorbidities, lack of access to medical care, definitely lack of access to specialized medical care like our docs have, regulatory requirements. So if something happens, obviously sometimes you all need a signed note script from the doc just to make sure you're covering all the regulatory requirements. Could be a fall, medication error, whatever it is, we have docs available to do that. And just simply your primary care doctor lacks availability. So it could be 10 p.m. on a Friday and you're calling your doc and they're saying go to the ER. Well, our docs could actually treat and assess over that call. And again, have that experience with this population to treat properly and interact with that individual. So just summarizing here, the emergency room experience, and another reason why we've developed as a company. For individuals at IDD, for all of us, the emergency room experience is frightening. It gives exposure to other infections. Your transport there is traumatic at times. We're trying to prevent that if we can, obviously, and we'll go over some numbers of how often we do prevent it. But I think when we look at individuals at IDD, the one piece of all this that we see as most important is the disruption of routine. Going to the hospital, sitting there for hours, missing medications, adding medications, having tests that maybe aren't necessary because the understanding is just not there. We try to prevent that if possible. Again, keep those individuals in the community where they're comfortable and treat them there when possible. The other side of it is obviously staff and caregivers that help these individuals. So we have staff shortages throughout this industry. We know that very well. Caregivers are burned out right now. So having that ability to prevent hopefully another trip to the ER, to the urgent care, waiting hours, seeing more docs, more nurses, we try to prevent that if possible, obviously here. That's a big reason why we developed. So I mentioned this a little bit, but we provide access to doctors specialized in IDD, go through a curriculum, and it's every day of the year, just to summarize it. It's every holiday, every hour we're available. Our docs are on shift, not on call. So when you call in, we have doctors available all the time that are sitting, waiting for these calls coming in. And because of their extensive training, they understand the special needs of this population, the challenges of group homes, of DSPs, nurses, and the challenges simply of the families that are caring for these individuals to help support the entire ecosystem of these individuals and their entire caregiving system. We get asked a lot, why call Station MD? So to summarize it, we answer all medical questions that come in. That can be everyday questions or it could be potentially serious. So your everyday questions might be, I give a medication at the wrong time. What do I do? Is this okay? Is it an emergency? I'm about to run out of medication. So we get a lot of calls where seizure meds maybe are running out. We could give gap refills to get you through the weekend or whatever it is to get to your primary doc. I have a cough. It's progressing. It's getting worse. Should I be worried about this? Pressure is running a little bit high. What do I do now? So you're kind of everyday type questions. I like to summarize this into whenever you think, should I worry about this with this individual? You could call us and we have doctors that could help you work through that whole problem. And then there is potentially serious questions. So you fell, potentially hit your head. Our docs will assess neurological assessments and see if there's any change in behaviors, work with caregivers to understand that person's situation. Vomiting is getting worse, a fever that's getting higher, a pain that just doesn't seem to make sense, it's getting worse. These are all reasons why people call Station MD. We get a lot of calls also where the individual just is kind of yelling and just can't verbalize what's going on with them. Our docs are trained to assess maybe what's causing that to happen. So again, any kind of medical advice, we're here to support. So why are we important? We really value this slide probably the most. We really are here to improve quality of life overall. Number one for the individual, but also for the caregivers involved. So we really want that individual to stay in the community with friends, working, listening to music, playing sports, volunteering, day have, whatever it is. But we really want to empower good access to quality care, specialized care for these individuals. And it really is the ultimate person-centered care we look at it as, because they could choose to call us wherever they're at. Their caregivers could choose to call us wherever they're at. We've gotten calls from work. We've gotten calls from home, obviously, from at a sporting event, they got injured. As long as you have a tablet or a cell phone with Wi-Fi or data to call in on a Zoom type app, you can call us. You also are able to call in via just a regular typical phone call. Just our docs might be a little bit more conservative if they don't have eyes on the person. So just kind of summarizing who benefits overall from using Station MD. There's different, obviously, buckets who benefit from this. The primary one being the individual themselves. The people with IDD will benefit from this the most. However, caregivers, support providers, and provider agencies, administrators, and even supports coordinators in counties will benefit from this as well to give more choice to these individuals. But looking at the individual themselves, they receive immediate access to specialized docs who understand their unique situations, reduces time and energy spent addressing their health needs at a higher level of care, if unnecessary, improves overall quality of life, and empowers the individual to thrive in their community where they're most comfortable and enjoy being. The caregivers and support providers, they receive immediate access to doctors who can give guidance. We don't expect everybody to have the knowledge, the clinical knowledge that these docs have developed through the years. So we're there to support that and give that advice. Reducing trips to ER and urgent care, obviously one of our primary goals. It offers peace of mind and alleviates stress when you're not having to make that decision for the individuals, and we have the doc to help. And prevents caregiver burnout and staff shortages. We've seen provider agencies we worked with, there's been a higher retention. We didn't see that coming, but they enjoy having that support. The nursing teams enjoy having that support of these docs. And just for the agencies themselves, obviously, expands options for these individuals, reduces critical incidents. And if there is a critical incident, we're there to provide a physician assessment to give documentation on that. And just again, giving overall more choice to these individuals and caregivers. The step-by-step process, I just show this because it's very simple. We do provide education to whoever would like it. However, you don't need education. So if you sign up for the stat service and choose Station MD, it's a simple phone call. There you will get a receptionist that'll collect some information. We do like to get as many vitals as possible, typical ones, heart rate, pressure, temp, pulse ox. You don't need any Bluetooth type equipment. Whatever equipment you have is great. And again, you don't even need all of that, but we prefer it obviously for a more thorough assessment. We have technical assistants there to help you through that if the individual calling doesn't know how to take the vitals. And also just to get you connected to our app if you have a tablet or phone available, and they'll get you connected right to the physician, and then the assessment will start. So looking at this, you all might be very familiar with this already, but just to kind of highlight how to enroll individuals for our services through their ISP. So obviously you're going to work with supports coordinators and AEs throughout the state to get signed up. But you can see the waivers here we're eligible for: the consolidated waiver, community living, and the PA person family directed support waiver. We are an approved stat service again. So specialty telehealth and assessment team is what that stands for. Sports coordinator work with individuals, agencies, families to get signed up. I do have the procedure code on here for anybody that would like it. So W7032 and HCSS. And once added to the ISP, we are tracking that report at HCSS daily. We see a lot of individuals coming on already. So we're tracking that, ensuring those files are in our system, and then their access to treatment is immediate.
Just to add to that, Jeff, if you can go back to that last slide, you wouldn't have to wait until the end of the year, the end of the fiscal year, whatever that might be. You can go in and have the sports coordinator create a critical revision starting today if you wanted to, and they would add that W7032 in that ISP, and they would then just have to be approved by that administrative entity. And then we would see that on our end in HCSS when we run our reports on a daily basis, see who has been signed up. And they would then be live with us with Station MD and can call unlimited calls per day, per month, per year.
That's true. That's a good point. So this, when added in the system, is added as a unit. One unit covers you for unlimited visits. So one unit is 1 month of care from Station MD in HCSS. So they could get up to 12 units, obviously, for the year, but that's unlimited calls, as Drew said. That's a good point. So just quickly to look at some of our clinical and some economic outcomes. Just overall, last year I pulled data to look at 2023. We had about 44,000 visits last year across the country. We had a 93.1% treat in place. So that means that we were able to treat individuals in the community wherever they were at calling in. 7% roughly had to go to a higher level of care, urgent care, ER. That's where our physicians will call ahead of time to have that peer-to-peer conversation and kind of warm handoff, have that discussion of this is what's going on with that individual. As we see these individuals, we'll also have a history in our system and give a heads up, hey, this person has a history of dental issues, whatever it is that might be causing pain, just to be aware of that. Just to give that, again, warm handoff and hopefully make that transition to that higher level of care a little bit easier. And I won't go through this whole thing here with diagnoses, but just to show you some of our top diagnoses we've seen in 2023, we looking back at data, anything from very general of unspecified body region injury, all the way up to, constipation, conjunctivitis, COVID, fall and hit their head. It really runs the gamut of diagnoses that we're seeing here. In the darker blue, you can see where we were able to treat in place, lighter blue where we referred out. So obviously some of your more serious conditions, we may refer out, but again, still overall treating in place a little over 93%.
And just to add to that, that also just goes to show that we are also not just keeping everyone at home or keeping everyone in their community. Our physicians will call those ER doctors ahead of time if they are referring the individual to go to the ER. So there is that nice communication of, hey, here's what I'm seeing when I am evaluating this individual. I am recommending they come to the ER. Can you please be ready for them if possible?
Yeah, that's a good point, Drew. And then on top of this, doesn't show up on here, but a lot of our calls come through medication type management. So they took too many, they missed it. There was an error. We get a lot of those calls as well, and our docs can reconcile that, help out the staff. Just to kind of highlight some of the benefits we've seen that we don't track necessarily at Station MD, but our partners have tracked through the years and kind of publishing on our behalf, which we're really proud of. But this is one agency in Pennsylvania. I won't go through all the details, but we teamed up with them a few years ago. Started with some individuals, expanded upon that, covering more individuals at this agency, and they saw savings roughly over the course of a year approaching $100,000. And that really goes back to staffing, transportation, overtime. So that's stuff we can't necessarily track, but we're hearing. A recent one I just heard this week, again, in about 7 months, approaching $40,000 in savings on similar types of scenarios with staffing, transportation. So again, that's support that we can give. If that can help companies save a little bit of money, we know it's tight, and also help with retention, hopefully, of staff, we're here to do that as well. And that's a secondary benefit for our services. So that's kind of a rundown of Station MD, our services, obviously, and where we fit right now, again, as a stat service in the Pennsylvania waivers. But we really want to offer to everyone on the call, if you'd like to have an individual meeting with us, reach out to ourselves on here. This is our contact information, myself, and then Drew Simonik, obviously, on here as well. We're happy to meet with you, your team, whoever you'd like to bring us in on. We want to give some education on this. And that's what I have, Patrick and Craig.
Yeah, thank you, Craig. I think you beat me to launching our poll, so we won't, well, everybody know if you're interested in a direct contact, we think this is a great service. So we appreciate you guys coming out. A lot of great questions and answers in the Q&A in the chat today. So we appreciate the dialogue. So I think maybe just a few points of clarification, and then I want to bring Craig in because Craig has direct experience working with you guys, and he has, I know, shared with you and with me, some of the benefits you're talking about directly from his direct experience. But scope, it seems to be very clear. This is all the waivers that you mentioned. There's a code. It's a monthly fee, basically, and you are the provider and you are billing ODP. So I want to make sure I'm restating these things clearly. And I see you nodding, Jeff. So I think that, I want to let you jump in with any of that. I want to remind everybody, if you think back last year, we showed the budget slide a little bit earlier. Last year, this investment was put into the budget. And I don't know what it was called then. I'm curious, Jeff and Drew, is stat a PA specific term? It is. Okay.
It is. So, yeah. That was specific to here. Other states for waiver service, it is different terminology. Yeah.
Okay. Yeah, I expected such, but I know you have an 877 number with stat. I was just curious if it's something that you kind of brand Station MD that PA has adopted, or PA sort of came up with the terminology. But I know just recently they were happy to announce the procurement of Station MD as a vendor. So this is open, as you said. So we encourage folks to contact you. I know you put your contact information up, but we think this is a really great service. And Craig, let me bring you in both to sort of comment on anything I might have missed from our members, and also to talk a little bit about what you've shared with Jeff and Drew about your experiences at ARC Human Services.
Yeah, so I just a second about the things that maybe I Drew and Jeff covered a lot of the details about the service itself, which I think is amazing. And we are one of the people that we have it in about a third of our residential sites at this point. We continue to grow and expand it, and it has been incredibly powerful, especially for people who are more medically frail living in the community. We are seeing some incredible savings in terms of staffing and just great care for people. One of the things that they didn't mention is that Station MD also offers a really rich library of training that can be videos that you can share with staff just to educate them on things like, basic medical, how do I take care of an ostomy? Just basic content that is available as part of the service that our staff have found incredibly helpful, our nurses have found helpful, and that just comes along with the service, again, with the goal of providing a great care for people, but a great experience of that care too, so that people can just get the service right in their house. So can't speak enough about it. I think it's really great for the people that we support. And I know my friends at Mainstay they're the ones who we started this with, and they've been doing some amazing work with this as well. And I'm sure you know, again, it's the same experience and outcome.
Hey, for all of you guys, since you have firsthand experience as well, Craig. So I know you mentioned in your talk about the uploading of notes. So can you elaborate a little bit more on terms of like if people are using, I guess, unique EHR record keeping systems, are you involved in sort of taking that all the way out into their record or not?
Yeah, so it's a good question. So a lot of clients choose to give us, say, read-only access or some type of limited access into their EMR. We'll get a login and we can upload our notes into that at that point. So we are working on some integrations right now, full integrations. It's limited at the moment. Obviously, we're rolling that out. TheraP is probably our first one that's going to be happening. But right now, a large part of our provider agencies prefer we just log in and upload our notes in there for them. Again, you don't need to have an EMR. We could email or fax if that's still your process. But we have that, and we've been able to develop specific workflows for each agency if needed. That's where that technical assistance I referred to comes into play. They're on that call, and they can kind of work directly with whoever's calling in to make sure the note comes over successfully.
That's great to hear. And then go ahead, Greg.
I was just going to say, just in terms of day-to-day experience, for those of you who want that information, so StationMD uses an electronic health record called Station Connect. It's their record. And even if you don't have integration, it will send you a notice that said this person received a service. You can log right into Station Connect and read the notes, see what the follow-up is. Our clinical teams have found that incredibly helpful, just to check in on stuff. You know, we'll get a notification that there was a medication issue, and the supervisor of the unit or the director of the unit will reach back out to the work unit and sort of find out what's going on, trying to get in front of problems before they happen again. But it's another good tool to just track and make sure that you're right on top of everything that's happening.
Yeah, and I see a couple of questions here. I just want to clarify a few things. So we do work a lot with primary care physicians as well. We try to team up with them. We're not here to take over primary care. We're here to kind of fill in those gaps and supplement. So we work directly with them, not only the ER docs. And looking at, I'm seeing there's some questions about units and that. So yeah, 1 unit is 1 month. That's in there, and that's unlimited calls. So again, as Patrick mentioned, we are paid directly through PA waiver. So we're funded by that, not you all, obviously moving forward. Just a couple clarifying points there.
Right.
And we do have a question out there that I think Drew and Jeff can answer. If the provider is already using StationMD, how will ODP be transitioning this for waiver funding? What does that process look like for that provider?
Yeah, good question. So first of all, please reach out if you're already a partner of ours. We'll kind of help with that. But there is a process we've worked with the state on with ODP to help transition those members over. It's happening currently. We're working on it at the moment. But Drew has been kind of integral in working with AEs as well to ensure this is moving along, and we're working with the state. But there is a process in place, and please feel free to reach out to me directly, and I can have that conversation for your specific members. Yeah.
Yeah, and really on our end, it's just us reaching out to some of those supports coordination teams or AEs to figure out if there is a holdup or what we need to do to kind of speed things up. So like Jeff said, just reach out to us, and if we could kind of communicate it as well. Sometimes it's best coming from you, but if we could also communicate with the people that need to get it approved, we will.
And follow up to that, guys. So, Craig and I were trying to kind of run the numbers again. We know it was proposed last year, but capacity, you've mentioned all the waivers. So is it your sense that there's any kind of gatekeeping going on, or if somebody has a desire and a need that you can pretty much apply, or is that not the case? Is there going to be certain criteria that only certain folks you will get approved for StationMD to provide those services?
Yeah, to our knowledge, there's no criteria on our end for sure. There's no age limits. There's nothing diagnostic specific, and the state is not placing limitations as well. And as far as resource allocation, we prepped for this. So our docs, we are staffed up to obviously handle a large number coming in. We know there's a large number in Pennsylvania that are eligible for this. The only limiting factor is probably what waiver you're eligible for, if it's capped or uncapped. Our service is obviously not a very expensive service. However, we know there are people at their cap. So that's the only limiting factor that I'm aware of so far, Patrick.
Yeah, that's great. Great to hear. So really, it doesn't sound like there's any impediment with you want this service to talk to you guys, talk directly to ODP. If you're already using it, it sounds like you guys will help facilitate that. And as you say, I mean, it's not that expensive. So it would probably be just for those people already at the cap or who have exceeded the cap that might, might bump into an issue on that. So that sounds great. I really want to thank you guys for being here again. We'll share with you, any of you members who have indicated you want to follow up, you certainly can reach out yourself with the contact information that Jeff and Drew have shared. Again, we really appreciate the time you've taken today to kind of educate us to this, let us know what's available, and members, it's really something we think that everyone should consider in terms of really all the benefits that they talked about, that Craig just talked about. So thank you guys again, and feel free to circle back to us. Any questions, anything more you would like to share, we'll certainly get that out to our members.
Great. Thanks, Patrick and Craig, for having us. Thanks, everyone. Appreciate it.
Appreciate the time.
Thank you, guys. And then Craig, I'll have you kind of help me because I feel like a lot of this segues into a lot of the work you've been doing recently with the ODP Technology Task Force. I know you've had a couple of meetings, and our next guest of the day we want to bring in is Constance Harrington from Shift. So Constance, welcome. We'd like to invite you in to join us. I know, I believe you have some presentation materials you'd like to go over too, but welcome. And I know we've all talked recently this week, so Craig has talked about shift credentialing. We had some conversations about technology first philosophy. I think most members are certainly aware, shift is one of the credentials that's very involved and embedded in the ODP waiver. So we're really grateful that you can join us today. Thank you.
You bet. Well, good morning, everyone. As Patrick said, my name is Constance Harrington. I am the Director of Education and Accreditation for Shift. So I've been working with people with intellectual and developmental disabilities for, I hate to admit it, but probably right around 25 years. That's been primarily within provider organizations. My roles kind of ranging from service coordination, case management, to residential programs, to program development and leadership. So at any rate, years ago, when the whole idea of utilizing technology to support people with disabilities really started to gain traction, I had the opportunity to build a technology program from the ground up for a very large service provider. And in the years since then, I've had an opportunity to work with multiple organizations to develop similar programs. And I've also had the opportunity to collaborate with states to develop waiver language and supporting systems and processes in order to support a technology-first service model. So today, I'm really proud to be part of the Shift team, where I have an opportunity to help people learn about and implement technology-first best practices. Now, before I dive into my formal presentation, I definitely want to thank Craig and Patrick for inviting me to speak with your group. I know that everyone is probably in a slightly different place in terms of their knowledge and experience with technology as a form of support. So I thought I would just spend a few moments bringing us into alignment, and I want to just kind of talk about a few basics before moving on. Okay, so in your role, I bet you have heard the terms person first, employment first, and technology first. So how in the world can everything be a first? And I think that is kind of confusing. So I'd like to offer just a little bit of clarity there. So as you know, a person first approach means that people are at the heart of services. People, direct the course of their lives. They're involved in the selection of the services that they receive. Great, we're cool there. Now, a technology-first approach is really dependent upon a person-first approach being firmly established among supporters and within an organization's culture. Technology-first absolutely does not refer to putting technology before the person. What technology refers is it refers to this idea of considering technology solutions rather than defaulting to the more traditional in-person service model. Okay, so with all of that being said, there are some key tenets to technology-first approach to services, and I want to just cover 4 of those very briefly. So technology solutions are first and foremost, really intended to help people improve the quality of their life, to gain or maintain independence, and to achieve their goals. So with that being clearly established, the implementation of technology solutions like remote support often does result in reduced costs and staff efficiencies. Next, each and every person supported should be considered as a candidate for enabling technology, and that's regardless of their disability or their skill level. So the myth that technology is really only for people with mild disabilities is perpetuated by this abundance of stories and videos that circulate that describe people moving from group home living situations into their own homes and apartments. And while those are amazing achievements, I definitely don't want to minimize those, and they should be celebrated. They're not representative of all of the possibilities that are presented by technology to people who have moderate and significant disabilities. So in reality, everyone can benefit from using some type of technology. You know, so for example, the ability for a person to be able to control lights in their home is taken for granted unless you don't have that ability, right? So small acts of independence like that can be a big deal for the person. So it's really important that we consider how and not whether technology can benefit the people that we support. So it's not about the technology, it's about how the technology can help create more independence for people. Yeah, I think, yeah, I'm just going to leave that there and move on to, I guess, my next key tenet here. Now I'm going to do that. I changed my mind. I'm going to go ahead and spend a couple of minutes here. Technology really, there's three kind of important concepts that I want to highlight here. Technology is not really an all or nothing approach. So oftentimes what we find is it's better to start small and give the person an opportunity to increase their confidence and build upon success using technology. So the second thing, the second part of that is that strategy can also be really helpful when there's reluctant team members. So helping starting small and getting some success behind the person can often help decrease that resistance and get more team members on board. The second thing that I want to mention here is that the people that you support don't necessarily need to like or be interested in or understand technology in order for it to help them attain their goals. I know that sounds kind of weird, but so for truly person-directed goals, technology really is just a means to an end. It's one tool in your toolbox that you can use to help people attain their goals. And third, I also want to mention that the right of everyone to make choices and mistakes, we call that dignity of risk in the field, it's an integral part of self-determination. So you've likely had that conversation with team members in the past, and you'll certainly continue to have that conversation in the future as well, particularly as you bring forward this whole idea of using enabling technologies to support outcomes. Okay, so that's the end of my soapbox right there, I guess. But it is the third tenet I wanted to highlight is it's important for you to know that a technology-first approach to services does not equate to eliminating in-person support. It does involve the reallocation of staff, allowing people to benefit from technology while still receiving the necessary in-person supports. So ideally what happens is staff members are directed away from doing for people and toward enabling people to take ownership of the things that they can really do on their own with the support of technology. And so as dependence is reduced, staff should be able to take on other responsibilities that do require in-person support. And this is really important. I'm going to talk about this a little bit later on, but there is definitely this trend for staff members, family members, guardians, as you start to talk about technology as a possibility, that automatically think, well, oh, geez, you're trying to remove the human element from services. Absolutely not the case at all. And I promise I'll dive into that a little bit later. But also the fourth tenet is that the balance of technology and in-person support is going to be different for every single person that you work with, because it really does depend upon the unique needs and circumstances of that person. So as an example of what I mean here, the support needs of, say, an older adult who's been living independently for years, but maybe has recently experienced some difficulties with mobility will be much different than the needs of maybe a very young person with CP who's moving into their own apartment for the first time. So in both cases, technology solutions might be very appropriate, but the implementation process would look very different for each person. Okay. So the next thing I want to just spend a couple of minutes talking about is I want to address this whole myriad of terms referring to technology that's used to support people with disabilities. So I'm sure you've heard the terms assistive technology, adaptive equipment, durable medical equipment, enabling technology, and the list seems to go on and on. Do they mean the same thing? The short answer is no. The definitions are different, even though they are often used interchangeably. And so one of the reasons the waters are so muddy here is because individual states, particularly in waiver language, use the terms differently. So as far as SHIFT is concerned, I will tell you that our focus is on enabling technologies. And what that term refers to is it refers to products, devices, and services that promote independence and self-determination. It's the easiest way to define that. Okay, so now that I've kind of covered a few of the basics, I want to move on to how SHIFT could support you through the process of adopting a technology for service model. So let's start off with what SHIFT actually is. SHIFT is an online education and accreditation platform. We are designed to advance technology first, the technology first movement through standardized best practices. Now, since all of our courses are online, people take courses when it's convenient for them. Our content's designed to appeal to people with different learning styles. So we have audio voiceovers for all written content, lots of videos, a variety of interactive components that's really designed to enhance that learning experience. Now, some of the reasons that I think that you would like our platform in our content, those are just some of the reasons that I think that you would enjoy some of our platform and our content. So, but let me talk about just a couple of different components. So first, education. So at SHIFT, we know that in order to be successful with adopting a technology-first approach to services, people at every level of an organization need to be knowledgeable about and involved in that process. And so our credentials and certifications are designed with that philosophy in mind. So I'll spend just a few minutes telling you about our credentials and our certifications. So the ETC, we use lots of acronyms. It's called the Enabling Technology Credential. That's really most appropriate for professionals who specialize, excuse me, really most appropriate for professionals who need a foundational understanding of technology integration. So generally speaking, those are your direct supporters. So the Enabling Technology Credential involves taking fundamentals 1, 2, and 3 as well as an exam. The credential itself, we tell people to expect about a 5-hour time commitment to complete it. And then just also as a side note, SHIFT's Enabling Technology Credential is also credentialed through an ABSP. It's also important for you to know. Now, the second type of certification then that we offer is the Enabling Technology Integration Specialist certification. That's quite a mouthful. We call it ETIS for short. And that's actually really most appropriate for professionals who specialize in the integration of technology. And so these are folks that work with or for organizations or states to complete assessments, to complete plans, to identify and implement appropriate technology solutions, to provide training, to serve as a resource and a mentor to other staff members. So their training consists of fundamentals 1, 2, and 3. And then they'll have some specialization coursework. They will also have a project that they complete where they take their learning into practical application. Now, this particular certification, we tell folks to plan on about a 15-hour time commitment. And just as a sideline on the ETIS, as well as SHIFT's ETIS certification meets Pennsylvania's waiver requirement for providers who want to adopt and implement technology. Now, the Enabling Technology Navigator Certification, or ETN, is a certification that's really most appropriate for people who are responsible for developing and writing person-centered plans. So the ETN, again, involves the fundamentals 1, 2, and 3 coursework, specialization coursework, some live instruction, as well as a practical application component through a project. This certification, we tell people to expect about a 15-hour time commitment to complete as well. And finally, the Enabling Technology Leadership Certification, or ETL, is really most appropriate for organizational leadership, including the person who might be spearheading this initiative. The ETL, again, involves the Fundamentals 1, 2, and 3 coursework, its own specialization coursework, an experiential learning project where people are able to take their coursework into practical application. And then also we expect that this takes about a 15-hour time commitment. So a couple of details about all of our credentials and certifications is that they are all valid from 2 years from the time of enrollment. So we do require that credentials and certifications be completed within 90 days of enrollment. And the reason that we ask for that is it's really designed to maximize learning. So that's the best practices in the world of education, but also to help ensure that the organization is able to make forward progress with their technology initiative in a reasonable period of time. Now, like most professional certifications, there's continuing education requirements that are in place for all certifications. So the ETIS, the ETN, and the ETL. And that is 10 hours every 2 years. So but Shift does recognize, Shift does obviously recognize the value of ongoing education, which is why we have that requirement in place. But we also know that providers have limited resources. So what we do is we actually offer virtual sessions to meet those continuing education requirements. So in a nutshell, there's no additional fees for any current learner to participate in any of the sessions. They have plenty of opportunities to earn all those continuing education hours just as part of their involvement with Shift. Now, the second component of Shift that I wanted to spend a few minutes talking about is the accreditation process. And so, many organizations actually decide to pursue accreditation in addition to earning these credentials and certifications. And the reason for that is because we use a highly collaborative approach to accreditation. So it's not a circumstance of where we come in and like an auditor and use a checklist to say, is this present? The accreditation process is really intended to help organizations bridge the gap between education and practical experience. So to help illustrate my point, you take a few moments to think about your academic experience in college. So you were likely, or hopefully anyway, exposed to a lot of tools, information, and resources. But in order to really, develop and hone your skills, you really needed some practical experience. Some of you maybe, were involved in practicums or things like that. But many of you probably really got that in the form of your very first career-oriented position, right? So earning a credential or a certification through Shift is really similar. To get the most out of your education, you really need to experience, you really need the opportunity to, develop and hone those skills. And so during the accreditation process, Shift partners with organizations to serve as a guide, as a resource, and a mentor to help you establish best practices, systems, and processes to help your organization be successful with the adoption and implementation of technology. Now, we have a fairly short period of time today, so I'm not going to go into our accreditation process in detail, but I did want to just pop this process flow map up here for you to review, just to understand that there are many different components of accreditation, and each of these components Shift guides organizations through and works with organizations to develop each of these systems and processes that you see up here on this process flow map. If you want more information about this, I promise you're going to get my contact information at the very end, and I'm happy to walk you or anyone else in your organization who are interested in learning more about that. Okay, so here we are. If technology is so great, if it's so beneficial, then why haven't all organizations adopted this technology first approach to services? So let me just talk for a few minutes about what's really needed to be successful with this kind of an initiative. So first of all, I kind of alluded to this earlier, but we know that organizations who have moved away from viewing themselves as caretakers and really toward viewing themselves as supporters are more likely to be successful with adopting a technology-first approach to services. That's, again, ideally because staff are directed away from doing for people and allowing people to take ownership of the things that they can do on them. So we also know that many direct supporters still kind of view themselves as caretakers, serving to protect and shelter their people. And that, while it's always the best of intentions, I believe, it is definitely kind of an approach that requires some adjustment. And so there is a process of ongoing education and training that's needed with our direct support professionals. So second, organizations who welcome innovative ideas and really avoid becoming too comfortable with the status quo are more likely to be successful with adopting a technology-first approach to services. Complacency, fear of the unknown, kind of an unwillingness to take risks, closed mindsets. Those are, all kind of ingredients for failure. But even in organizations who that are highly adaptable, this process creates anxiety, kind of uncertainty and discomfort. And so the best organizations really do recognize that dynamic and work proactively to minimize the effects of that type of stress. Third, I want you to think about this. Boy, it's going to sound like I'm really discouraging you here. I promise I'm going to come full circle with this. It takes a lot of work to successfully implement a technology-first approach to services. So you'll be developing new policies, procedures, systems, and processes. That takes time, resources, and expertise, all of which are in short supply for provider organizations. That being said, even organizations who commit to hiring dedicated personnel to support this process don't find themselves on an easy road. So few people really do experience expertise in this area, meaning that organizations are often left to compete for those limited resources or to develop knowledge and skill among their existing staff members. So that's also a reason that you should be partnering with Shift, because we serve as kind of a guide and a mentor through the adoption and implementation of a technology-first approach to services. So interestingly enough, one of the first decisions that an organization often makes is whether or not they're going to use existing staff who will other positions in their organization to implement this initiative or to hire new staff. And so there's obviously pros and cons to each strategy. So while using existing staff to spearhead the initiative is cost effective, it can result in staff being overwhelmed and thus failing to meet expectations and deadlines. Having existing staff support the initiative means that those staff members will probably need additional training as they assume their new responsibilities. If an agency adds a resource, the skill set can be integrated into the qualification and hiring process. But that being said, existing staff members are already really familiar with an organization's systems and processes, both of which a new staff member would need to learn. And that would definitely delay the forward progress with the technology-first initiative. The other thing to be thinking about is your existing staff members have already cultivated relationships within your organizations, people supported and family members, staff members. So that means that those folks are likely to have an easier time identifying candidates for technology and getting buy-in from other staff members. So one strategy that's worked really well for a lot of organizations is to hire one or more existing staff members to exclusively support the technology initiative. So just hiring from within. And that approach obviously has a lot of benefits. It allows the agency to capitalize on the staff members' existing knowledge. It allows the organization to tap into those established relationships that may already exist. And then the other thing too is it allows the organization to invest into an established known employee. So you'd be hiring somebody that you were already familiar with, who had kind of a proven track record with you. And then also it gives the staff member an opportunity to learn a new skill set. So there's some great advantages to that. There are other challenges associated with adopting a technology-first approach to services. you're familiar with these or have at least heard of some of these. There's limited training opportunities. That's actually coming from, these are actually all coming from a nationwide survey that was done in 2021. But there are limited training opportunities. Shift was really born from that need. We are the only company that offers technology first credentials, certifications, and accreditations that are specifically designed for the IDDD field. Second, providers oftentimes face reluctant or even sometimes hostile attitudes toward technology adoption. There's a number of reasons for that, but nearly all of them stem from a lack of knowledge and kind of inaccurate assumptions. And so while Shift obviously believes in the importance of our curriculum, we recognize that not all staff members will have the opportunity to earn one of our credentials or certifications. So that being said, it's very important that everyone receives some basic information about enabling technology and technology first best practices. And that foundational education really does help increase buy-in and get team members on board with using technology as a support. And then another challenge we see is that providers, kind of depending on the state, can struggle with identifying and securing funding options for the purchase of technology. So that can remain an issue even in states who have allowed for the inclusion of technology support into their waivers. And that's largely because of funding caps, limitations on products, services, or devices, or even sometimes cumbersome processes for trying to access that funding. So despite all of those obstacles, the first and best place really to start identifying funding sources is in state waivers. But if a product or service or device is not covered as a waiver service, or if that funding cap has already been met, there are also a number of other funding options that can be pursued. And the other thing to remember too is many providers actually choose to go ahead and purchase equipment without reimbursement because it supports the person's goals, but it also reduces expenses and allows for the reallocation of staff members. So many organizations have decided to spend the money themselves without reimbursement because of the benefits that are there. Okay. All right. So with that being said, I know I don't have a whole lot of time. I do see that there's some questions. I'm really hoping that today's presentation has been helpful, but I would like to take a few minutes to answer any questions or respond to anything that may be in chat at this point in time.
Thank you, Constance. Craig, I know we have a couple of things out there. Do you want to jump in? Yeah, and we'll launch our poll for those of you who are interested in learning more about Shift's education and credentialing programs. So thank you, Craig. Craig, what else do
we have a question out there, Constance. Do you have a directory of people who are certified who could be interested in contracting with an organization to help them get started?
We don't. We have contemplated that, but have chosen to not go in that direction. We do allow staff members, obviously, who earn credentials and certifications. Those are their credentials and certifications, even if it's earned within the context of an organization. So most of those professionals do list that credential or certification directly on their resume or their visas.
And in the last minute that we have, can you talk a little bit about the cost for the certification for staff and the accreditation?
Yeah, I think I definitely can. I will also encourage you to visit our website. We can post that in here for you very quickly. For our credentials and our certifications, the initial credential is $199 for 2 years. The initial certification for the ETIS, the ETL, and the ETN is $999 for 2 years. Those prices do go down on re-credentialing or re-accreditation to $149 and to $749. So those are just kind of some generals. As far as the prices for accreditation, we've also listed that out on our website. We're very, very transparent with our pricing, but you should know that accreditation is based on organizational size. And if I'm remembering right, depending on organizational size, it ranges from $750 for 2 years, all the way up to, I believe, $7,500 for very large organizations for 2 years. So the accreditation pricing is intended to be very reasonable as well. But if you're interested in learning more, again, I'll direct you to our website. We'll provide that information so you can do a little looking on your own. But I would certainly welcome you to reach out to me if you want to learn more. We'd be happy to set up a meeting and just visit with you or other people in your organization about what we might be able to offer.
Yeah, and lastly, our colleagues at Mainstay, Kim Sonnefeld, the CEO there, they just went through the reaccreditation process, and she has kindly offered that if anybody has any questions, that they can reach out to Kim. I hope I read that right, Kim. Don't yell at me if I didn't.
That's very sweet, Kim. Thank you for doing that. Mainstay's amazing, and they would be a great resource to reach out to.
I posted that info in the chat if anybody wants to grab their website and reach out to them. So.
Okay, well, thank you, Kim. Thank you, Constance. We also want to extend our gratitude to Jeff and Drew from Station MD from presenting earlier today. Thank all of you for being here today. Happy spring. Have a great rest of your day. We will be in touch with you very soon. Thanks, everyone.